So thank you and welcome to our first official all virtual meeting per our new bylaws and policies. Yeah, and I think there's a couple members not quite on yet who had RSVP'd. So give us a minute and we can get going. In the meantime, I know Hope had sent out the meeting package earlier today. So feel free to take a look at that and review the minutes from last meeting so we can vote to approve those when the time comes. Thanks, everyone. Okay, unless there's any objections from the folks running the tech here, I think we're good to get going. So welcome everyone. Thank you for joining us today for today's CHIPAC meeting. I'm Sarah Curiano, I'm chair, and I'll do my best to run a decent virtual meeting today. Before we get started, I just want to introduce Director Roberts. She's joining us for at least part of the meeting today and give her the opportunity to say hello and any welcomes and statements that she'd like to share with the group.
Is she able to unmute?
Is she able to unmute herself, or do we need to give it a figure that out? And yeah.
Oh, yeah, we still can't hear you. I just want to, while we're trying to figure out that technical issue, I just wanted to announce that the meeting, that remote closed captioning is available for the meeting, and the link is in the chat box.
Hello, everyone. This is my hello before they mute me up again. First of all, thank y'all for coming. Always glad to hear and see from you. Once again, I'm sure you're going to go through it. What people always forget is that Medicaid is primarily children, and that still remains, even with the not unwinding. Children are still dominant in terms of who we serve. And so we're glad you're committed. Three quick things. You're going to hear very, very soon that the governor's #1 health initiative is behavioral health. No surprise. If you're involved and you want to hear what he's going to say at the Behavioral Health Commission next week, you're welcome. Obviously, it's live streamed and you can actually listen to it. It's in 3 pieces. All the pieces are coming together. One is obviously preventative and management. Second piece is obviously crises, and the third is obviously recovery and reentry, because we're trying to look at this as a spectrum as you're going through in your behavioral health line. So that's be important. Second issue that's #1 is we did not hear about the public health emergency. So we keep going. Okay. I think Sarah's group is going to talk a little bit more about that with you, about what does that mean. But what it means is from us is that on November 12th, we did not get a stop date. So that means that the good is that we continue on providing services and care to all 2.1 million people. And we also have more time now to prepare for redetermining them. And the third one, which is what Dan is going to talk to you about, is what we are in the managed care delivery system. Obviously, we're working towards going to Cardinal, which is the combination of both Medallion and CCC Plus. But in addition to that, sometime next year, we will be reprocuring the entire managed care delivery system. This is important. Dan is going to talk to you about it. I'm going to emphasize it. We want your input. You have a small window, but the window is we really do want your input. And that's one of the big things we want to emphasize today. Because again, you're the person that talks to our members. You're the person that's involved in it, whether or not you're doing it directly or indirectly. And we want your opinions. We want your thoughts. We had in a formal meeting last week to have stakeholder and association meetings. Some of you had attended to that. But now we're saying as a particular subgroup of children and health issues, we really do want your opinion. So, Sarah, I'm returning it to. Oh, and one last thing. Why could I forget? Happy holidays. Whatever you celebrate, I hope that you take some time off and enjoy your holidays and your family. And I hope that for those people who get to have their children home, whether they're in college or in high school or elementary school, that you enjoy that particular piece of that season. For those who have outlived that and can say that that's behind you, please enjoy the lights and everything else that's out there. Okay, have a good, and I'll see you. Happy New Year to you.
Thank you, Director Roberts. So just as an all virtual meeting, as Hope said, the remote captioning is in the chat box. We're going to do roll call. Feel free to unmute yourself or put here in the chat. And we're just going to try to move through it a little bit slowly so we can all keep up. I think that's it for announcements. Yeah, so we're just going to go through roll call. Irma Blackwell.
Present.
Dr. Brickhouse. Dr. Brown.
Here.
Kelly Cannon. I saw Kelly in the chat before. Kelly, if you can't unmute for some reason, just let us know. No, we're not hearing you. So if we can possibly figure out what's going on with her sound. Michael Cook. Let's see. Heidi Dix.
I am here. Hello.
Right, your sound works. That's good. Ali Farouk. Let's see, Ali. Okay. Shelby Gonzalez.
Hi, I'm here.
Emily Griffey. Alexandra Jobna. Jeff Lenardi. Dr. Walker Harris.
Here.
Freddie Mejia. I see Freddie, and I know he was having some tech issues earlier connecting with the Wi-Fi where he is. So, but I see that he's here. Michael Muse.
Here.
Emily Roller.
Here.
Hannah Schweitzer.
Here.
Dr. Webb.
Here.
And that's good. All right, so we're just going to move on to business. Again, as we vote, feel free to vote verbally or just go ahead and put it in the chat. I also see that Ali is present. He put it in the chat, so we can mark him as present as well. Hi, Ali. Thanks for joining.
Sarah, this is Kelly. Can you hear me now?
Yes, we got you, Kelly.
Okay.
Great.
I switched to phone. Thank you. Thanks, Sonia, for your help.
Yeah. Okay, so we first just have some membership items to go over. So Tracy Douglas Wheeler, who is from the Virginia Community Healthcare Association, is stepping down from her seat, and she's recommended Martha Crosby to take the seat. Since the Community Healthcare Foundation is not a mandated member, we do have to vote. Her bio and member questionnaire are in the meeting packet. So if folks want to take a second to review that, and then I would need a motion and a second so that we could vote on that, on adding Martha to the committee. And Martha, if you're able to unmute and wanted to just say a few words, you're more than welcome to now.
Can you hear me?
Yes, ma'am.
Okay, because earlier I couldn't hear anyone, and I figured it out very quickly. But hi, my name is Martha Crosby. I work for the Virginia Community Healthcare Association. FQHCs is our membership. But before that, I actually worked for Delegate Roxanne Robinson in the legislature. So I'm very familiar with CHIP. DMAS comes all the time to our office to talk about healthcare initiatives for the state. And CHIP is one of the main things that's always been mentioned in the HWI committee. So I'm very familiar about the process and everything. And I've worked actually with Emily on a few things too in the General Assembly, so I hope she vouches for me. And so, but if you have any other questions, please let me know.
Thank you. And once folks have had a second to review, we would just need,
I'll move
there is someone
approval
move.
for Martha.
Does anyone second?
I'll second.
Um, all those in favor say aye or tape it. Aye.
Aye.
Yay.
Aye.
Great. And anyone opposed? Great. Welcome, Martha. Thank you for joining us. We're excited to have you. The next update is just that Hope, I'm going to turn it over to you. As we were going and updating with the virtual policy or virtual meeting policy, Hope noticed a few other things from our bylaws that just kind of needed to be cleaned up, that weren't necessarily pertinent or accurate anymore. And so she's gone through and made some of those changes, but we do need to vote to adopt them. So Hope, if you want to step in and explain what you've done, that'd be great.
Sure. Okay, so this is about halfway through your packet. The first proposed amendment to the bylaws is on page 4 of the bylaws. And if you look through these, it's the red font. So you'll see that there are very few, but these are just some technical changes that we spotted as we were making the updates about electronic meetings. So the first of the changes is in Article 6, Section 1. And basically here, rather than specifying in the bylaws exactly the amount of time in advance to reschedule a scheduled meeting, we would just remove that language so that we could comply with sort of by default with whatever is in the Code of Virginia. The new code language has separate provisions for emergency and non-emergency circumstances. And so I think some things have changed, and rather than trying to reflect all of that in the minutes and then have it need to be changed every time that we that there was a change to the Code of Virginia, we're just going to remove that and defer to the code language. The next change is, oh, I'm sorry.
Excuse me, I didn't mean to interrupt, but if you've taken roll, it's Michael Cook and I've meeting. I apologize. Thank you.
No problem. Gotcha, Michael. Thank you. So in section 5 under citizen participation, this is on page 5 of the bylaws. We just updated this section around public comment and comment from representatives of groups to reflect the current practice of the committee. And then the last major change is in section 10. And that just updates that section on the posting of minutes and meeting recordings and where those would be located, like on the DMAS website. So I think that is all for those changes. Let me put the, let me specify here in the chat box before we start voting so that I have a written record of this. Okay, so I guess we need a motion to approve unless there is discussion, if folks wanted to ask any questions or had any concerns.
I motion to accept the changes.
Second.
Seconded.
All those in favor?
Aye. Aye.
Aye.
Aye.
All those opposed? Great, the changes have been adopted. And we can, sorry, I skipped approving our minutes from our last meeting from the September 1st meeting. So kind of jump back up to CHIPAC business point A. Sorry about that, guys. And those are the first thing in your meeting packet after the agenda. And if you have a second to review, let us know if anything needs to be changed, edited, or we would just need a motion and a second to approve.
So moved.
Second, all those in favor of accepting the meeting minutes from our September 1st meeting, say aye.
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 Anyone opposed? No. Great. And then our last order of business is our 2023 schedule. So this is our final meeting for 2022. Somehow it's December already, and that is all the way back down in the meeting packet. Where are these in the meeting packet? Hope, are the proposed dates in the meeting packet, or are they not?
I'm sorry, they were sent as a separate attachment because people might want to reference them later. So I have that as a standalone PDF in the email from last week.
So for anyone who doesn't have that pulled up, I'll just, oh, they're on the slide. So yeah, they're up. So again, we just would vote. As a reminder, if it is not an all virtual meeting, there still are ways to attend virtually. And then if you meet one of the criteria, you can still vote. If not, you could still attend without voting. And we kind of decided June being summer and December being close to the holidays and leading up to session, those are the ones that tend to be most difficult for folks to attend in person. And so those were the virtual ones that we slated. We can only have 2 all virtual per year. And so this is our proposed schedule for next year. So if it is acceptable, we would just need a motion, a second, and then we could vote on it.
Motion to approve, Sarah.
Second.
All those in favor?
Aye.
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 Anyone opposed? Great. Well, thank you all so very much for that. And that is double checking. Yes, that's all our CHIPAC business for today. And so Director Roberts already introduced our next topic. Dan Pleen is here to speak a little bit about the MCO procurement plan, re-procurement plan, and hopefully getting some feedback from members. And then I think we'll probably let you know how to get more feedback if you have thoughts after the meeting. So Dan, take it away.
Well, Sarah, thank you. You've kind of done my whole presentation, so I will build upon what you said. And first of all, thank everybody for having me here at CHIPAC. I started my career many years ago working with the CHIPAC when I was the famous program analyst, and it's nice to be with you all again. Cheryl mentioned the procurement, and I'm here with an ask and a little bit of information and some to help you give us some feedback about the procurement. Before I start, I do want to say that we are in the process. Cheryl talked a little bit about Cardinal Care, and Cardinal Care is a rebranding of the current programs. It doesn't significantly change the delivery system or change benefits or change networks or change health plans. It is a way to sort of streamline the existing programs, the CCC Plus program, the Medallion 4 program, and fee for service into a program known as Cardinal Care. And we will be moving forward with that in the first quarter of 2022. And we'll be sharing more information about that with you as we get closer to the start of that. So To start, a good afternoon. I am Dan Plain. I'm the Director of Healthcare Services at DMAS. We are in the planning phases of an upcoming procurement, and I want to give you a quick overview of our current state and ask you for some electronic feedback to help inform our priorities and help with program design once we do the procurement. Now, I know that some of you were on our Medicaid Managed Care Advisory Committee meeting a couple of weeks ago, and we are grateful for comments provided in that forum. They've been very helpful and informative. For the majority of you who weren't present, there'll be an email address for you to reach out to us and provide some written feedback. Our upcoming procurement is an opportunity to build on our foundation, our managed care foundation, through new managed care requirements and program components, through the reprocuring of our health plans with updated evaluation criteria, reflecting current priorities of you all, the state, the administration. Our program goes back to the 1990s and has evolved over the years, especially in the last decade through the inclusion of long-term services and supports and complex care through the introduction of CCC Plus, and then again in 2018 with Medicaid expansion, and soon through the Cardinal Care Managed program, which combines our two Medicaid managed care programs into one comprehensive program. We have tried to continuously seek strategies to add value to our members and to our providers within our program. Cardinal Care will be another step in this direction with streamlined transitions as members move from one program to another. They'll be in one program, more uniform processes for providers and the MCOs. Cardinal Care will go live, as I mentioned, and we've started posting information to the member and provider pages of DMAS. Certainly feel free to go there at your leisure to get more information. In addition to program enhancements through Cardinal Care, we have successfully implemented additional evidence-based behavioral health services through Project Bravo, extended 12-month postpartum coverage, and added a community doula benefit to help improve birth outcomes for mom and baby. As Cheryl mentioned, children are still the bulk of our business, and it really drives what we do. We've also added a mobile vision services benefit to provide glasses in schools. We're very excited about that. And we've eliminated copays for famous members. We've had a number of advancements in recent years and added some flexibilities as a result of the pandemic. And as we're preparing for the end of the public health emergency, we'll be sharing information and talking about what this means for member eligibility and the future of some of those flexibilities that we've been operating under for almost 3 years now. We want to continue to do what we can to assist members through this transition, and we're working to ensure we have up-to-date contact information when the time for redetermination comes. We've been working with many stakeholders, the health plans, DSS, others, to make sure that we have a communication flow so members can update their information and we have the latest access to it to make sure that they continue their coverage, are referred to the exchange, or are able to find coverage elsewhere. So the next slide is an overview slide. We'll talk about the procurement a little bit. So if you would, thank you. So next page, next slide, please. In October, early October, Secretary Littell released did a press release announcing that DMAS would be launching a transformational new procurement to drive innovation and strengthen quality and accountability in the managed care program. We and the administration are targeting July 2024 as the implementation of the new program, and we will be sharing information with the public as we move forward with this work. If you would like to look at the press release, it is available on our website at the bottom of the homepage. I think it's the lower right-hand corner under press release is the topic. Next slide, please. So as I mentioned at the top of the call, presentation, we're looking for your feedback and your experience and your expertise, your history really as an advisory committee. I know you've got, 20 years plus of experience, and your ideas are critical to the success of our procurement, the success of our program. We've got 3 specific areas that we will be asking for stakeholder input on, and we ask that everyone please refrain from making comments on areas we do not have the authority to change, such as rates, eligibility criteria, or covered benefits. Next slide, please. The first prompt here in terms of seeking member feedback, what are the strengths of the current Medicaid managed care delivery system that DMAS should maintain or build upon? What works? What do you like? What has been successful? The second area that we're seeking feedback on is, where are there opportunities to enhance member and provider experience, better collaborate with key partners, and enhance outcomes? How to make that process easier and encourage more member interaction and provider involvement. And finally, the last item we're looking for feedback on is there anything that we are not currently doing that we should consider incorporating through this future procurement? Certainly, if there are actions or activities that other states are doing that you want us to consider or that you think are innovative, this is your opportunity to share that with us. We certainly encourage you to provide as much information or as many ideas as you have. We're certainly taking them all. Not sure that we can do them all, but we certainly want to entertain and encourage you to share with us and inform us on what your thoughts are around the program, how to make it better, and how to change it. Next slide, please. Okay, so we have an email address for you. It's here. Please feel free to share this with other colleagues you have, stakeholders, interested parties who you think might have an interest or might be able to add value to the program. We certainly encourage them to communicate with us. Send everything to the MCO procurement at dmas.virginia.gov email box. We do ask that you get us comments by close of business next Friday the 16th. And that's pretty much it. If you have any questions about this process, you can reach out to me or Hope, and we will certainly either answer your questions or get you to the right people to answer your questions. Thank you. That's pretty much it. Any questions from anybody?
Well, thank you so much, Dan. We really appreciate the opportunity to be included in this process up front. It's always easier to kind of have these conversations before things get in motion too far down the road. So thank you for coming. Last call, if anyone has any questions about this right now for Dan. If not, we can move on to the next agenda item. But you have his contact information as well as how to submit any comments to DMAS before next Friday or before the end of the day next Friday.
Thanks, everybody.
So our next topic is data and quality updates, focusing on the children's vaccination and preventative health. I know we've had some conversations previously, specifically about vaccines, wellness checkups, as well as the COVID vaccine rates in kids. Ali, this one's for you. I know you've been waiting for this data and update, and so we really just appreciate the folks at DMAS who've put it together for us and come back, and I'm just going to turn it over to them.
Hi, good afternoon. I'm Rich Rosendahl, and I'd like to take a moment to share some updates on our COVID-19 vaccination rates. If we could move to the next slide, please. Great, thank you. So it's an exciting time to be able to review this data right now because we're basically a full year past when, children between the ages of 5 and 11 were able to start receiving the COVID-19 vaccine. And obviously since then, in the late spring, children under the age of 5 were also given the clearance to start getting vaccinations from the CDC. So we do have about 6 months worth of data on the ages 1 through 5 and more than a full year of children ages 5 to 11 to go along with our 12 and up populations. So we do have some more insight into that. As we currently see, this is a chart by age category, which is valuable because as I just kind of alluded to, different age groups have been able to receive vaccines at different parts of the pandemic. And so this first category in the front is ages 6 months to 4 years, otherwise known as that 1 to 5 group. And so when we look at that, about 5% of eligible children in that age category have received at least one dose. So whether it's the blue or the green part of this bar, the orange represents the unvaccinated population. And then, yes, I just saw a little thing in the chat. Yes, this is for Medicaid members only. This is not reflective of the entire state. Moving to the next category, to the right, just a little bit, we do see a higher rate of fully vaccinated and partially vaccinated in our 5 to 11 age group. There, we have over 37% of eligible children have received at least one dose. So again, that's the group that's been eligible for about 13 and a half months up to this point. So seeing increases there since the last time we provided this update for everyone. When we look at ages 12 to 15, in that the middle section, that's about 58%. Then we're looking at 66% for 16 to 20-year-olds and 73% for members 21 and up that have received at least one dose or is fully vaccinated. So obviously, as the cohorts are higher in age and have been eligible for vaccines longer, we do see higher rates of vaccination. When we want to look at members enrolled due to pregnancy, 59% of those individuals have received at least one dose. And that does include members that were enrolled during the public health emergency. If we go to the next slide 20, we'll be able to see a basically like a heat map by region of areas that have of vaccinations by area. As we've reported in the past, the Northern Virginia region does have the highest vaccination rate, and then our Southwest and Roanoke regions have some of the lower rates in the entire state. So overall, the Northern Virginia area is vaccinated at a 70% or a 30% rate. So this graph is technically actually showing unvaccinated individuals, but we can obviously subtract that off of 1 in order to get that information. Thank you for the question. Yes, fully vaccinated would have been defined at this time as primary. Excuse me. I could certainly look into seeing about boosters or the bivalent dosage that was cleared for all this past fall, just to make sure that we're providing the most up-to-date information. But given the current state of where we're at with the vaccine and the levels that we're seeing, we were just trying to define it at least as those basis information. So I see Miss Cannon's question in the chat as well. So Medicaid rates versus the state do lag a bit, especially when we look at the younger populations. I don't have those numbers right in front of me, but I do know from previous previous analyses that Medicaid is a bit lower than the rest of the state when looking at the entire state, and then especially when we break it into different age categories. So we'll continue to monitor this and provide updates. I know that several of the managed care organizations are still having different pop-up events and vaccine drives. I know that the city of Petersburg was a site of one of those just a few weeks ago. So we look forward to being able to answer more of your questions. I know that we're a little pressed for time, and I know that Dr. Laura Boutwell has some great HEDIS updates for the rest of the group for our time slots. Thank you.
Thank you. Hi, this is Laura Boutwell. I am the Division Director for the Office of Quality and Population Health, and I'm going to move us into a discussion, as Rich mentioned, on our HEDIS results. Now, I did present in our previous CHIPAC meeting some of the behavioral health measures. And today I'm presenting more of the maternal and child health measures for this particular session. So I will be going over a little bit of a little bit of background HEDIS information. I'll probably move through it a little bit quickly since I presented much of it in our previous conversation. But we can go to the next slide. This is just a quick overview of what we'll be covering today, including defining the HEDIS measures. What is a HEDIS measure, talking a little bit about the impacts for measurement year 2020, and talk about the upcoming dashboard, which is very exciting updates there. So next slide, please. So just like I said, when I brought this up previously, but just as a quick refresher, HEDIS stands for the Healthcare Effectiveness Data and Information Set. The measures themselves are developed and owned by the National Committee for Quality Assurance, or NCQA, is one of the most widely used performance measures in the healthcare industry across the board. So and it provides a standardized way to measure performance. In Virginia, Medicaid managed care organizations are actually required to be NCQA and are therefore required to report all Medicaid HEDIS measures annually. And in order to do so, they work with certified HEDIS auditors to audit and verify the measures. And then those audited measures are submitted in a locked file to NCQA as well as DMAS for analysis. Next slide, please. So we're going to jump into some results, and we're going to talk just a few mentions of discussion for measurement year 2020. And just as also refresher, measurement year 2020 loosely is defined as calendar year 2020. However, that is not a perfect analysis for those that are looking, because some measures have there's some slight variation in the time period of interest, but these are all calculated under that measurement year performance for HEDIS. So just wanted to, as just a quick refresher, due to the COVID-19 pandemic, we did see decreased utilization of certain services. And there are some really important caveats for trending the data as we look at this information. NCQA themselves gave flexibility in measurement year 2019. And not because the data itself for that measurement year or calendar year 2019 was of concern, but provider for some hybrid measures that required medical record retrieval during the beginning of the COVID-19 pandemic was disrupted. And so NCQA allowed the plans to report either the current year or the previous year's results, whichever were higher. So there is a little bit of some issue with that data not necessarily truly representing measurement year 2019. And also, as we move forward, trending as we look at impacts it should be used with caution. We also had some issues with technology and immunization data that had prevented the MCOs from accessing the full VDH immunization registry for reporting for measurement year 2020. MCOs largely found some workarounds to it, and have since corrected the issue, but there is an important caveat to state there. Next slide. So we're going to dive into these maternal and child health measures that I mentioned. And I will also say that we have recently received and have been reviewing measurement year 2021. So we will be excited to share those results with you all for too long. But again, this is for measurement year 2020. And we do have a comparator to 2019. Even though I said to trend with caution, I think it is important to at least take a look at what is happening here. So for timeliness of prenatal care, we did see a slight decline in measurement year 2020 from the previous year, from measurement year 2019. This is a hybrid measure, so there may be a slight amount of potential inflation into that measurement year 2019 number due to the flexibilities that NCQA put in place. And so this is the HEDIS measure for percentage of deliveries of live births that received a prenatal care visit in the first trimester on or before the enrollment start date or within 42 days of enrollment in the organization. So it could be within that first trimester or within that enrollment period. Next slide. This is for the postpartum care measure. This is the HEDIS measure that is a percentage of deliveries of live births that had a postpartum visit on or between 7 and 84 days of delivery. We actually saw an increase here for measurement year 2020, and we anticipate that this is potentially due to the public health emergency itself, in which members were not being removed from the eligibility categories. Obviously, we have now extended postpartum care coverage to a 12-month period, but this is actually probably a representation of our mothers being able to access that postpartum care under the public health emergency and seeing that trending up there. Next slide. So we're going to jump into some preventative care measures around children. So NCQA has actually made a couple of changes around these measures. So you're going to see some new and slightly modified measures to what we're used to presenting to this group. One is the well child visits in the first 30 months of life. This used to be the first 15 months of life, but has now been split into two. So we have the first 15 months of life, and then the 15 to 30 months of life is the new measure. And so we do have trended data for that first part of the measure, and we did see a decline in that year, likely due to COVID, and decreased service utilization for well child visits. And we don't have trended data for the second measure, which is that 15 to 30 months period. Next slide. This is also a new measure, and some of you that have been receiving updates on HEDIS may remember the older measures, the child visits in the 3rd, 4th, 5th, and 6th years of life measure, and then there was another adolescent measure. NCQA has now actually combined those measures together. So this is a brand new measure that is the percentage of members 3 to 21 years of age who had at least one comprehensive well care visit with a PCP or OBGYN practitioner during the measurement year. So this is a new measure, so we have no ability to trend it, so we will look forward to sharing the newest information soon on how to trend. Next slide. So we get into some immunizations, and this is the classic measure that we've looked at, which is the combo 3 immunization status for childhood immunizations. And so this is a measure which is the percentage of children 2 years of age who received the following immunizations. I'm not going to read all of them, but if you want to take a look at all of those, and we did see a slight decline in measurement year 20 for that, likely a mix of COVID and potentially issues with being able to get information from the immunization registry as well. Next slide. This is a particularly interesting one because NCQA has really been trying to be a little bit more clear about immunizations for adolescents. And I think this is very interesting for Virginia specifically, because we are kind of bucking the national trends for immunizations in the adolescent category. As we saw earlier, we saw some decreases. We kind of expected that under the COVID-19 pandemic, but we're actually seeing a slight increase that's not mirrored in the national trends for immunizations for adolescents that you can see here for both combo 1 or combo 2 for the immunizations So this is the percentage of adolescents 13 years of age who had at least one meningococcal vaccine on or between the member's 11th and 13th birthday, and at least one of tetanus, diphtheria, toxoids, acellular pertussis vaccine, and have completed one of the other two combinations. So we have seen some increase in this particular measure for adolescents. And like I said, this is a little, it is interesting because this is outside of the national trend, and Virginia is seeing this increase. Next slide. So we're going to jump into dashboards, and I know I demonstrated the dashboard in our last meeting. That was for our measurement year 2019. So I just a refresher on the purpose of the dashboard is to demonstrate the quality of care, provide that transparency, and demonstrate our accountability to our members and stakeholders. Next slide. So we did develop that dashboard in 2021. The next release, it says will be updated with measurement year 2020 data anticipated to go live December 22. And I am thrilled to say it is now live on our website. So we do have the new, and I'm going to walk through a screen grab of it. It is a little bit different from our previous examples. But we do have that update for measurement year 2020. And as I said, measurement year 21 data is being reviewed and discussed internally. And we hope to be able to release a brand new version of the dashboard in first quarter 2023 that will include trending for the last 3 years, with a lot of caveats, because as we know, there's a lot of concern about the COVID, but it is important to take a look at and start to develop this ongoing transparency and accountability. So the next slide is actually a screen grab. It is somewhat similar to there are some similarities visually, at least with colors, to our previous version of the dashboard. But this actually now, the measure definition is moved from the bottom towards the top of the screen, right underneath the title of the measure, as well as you'll see at the very top, it says measure name select from drop down. Instead of clicking on individual Tableau based screens, you will now be able to use a drop down menu and select from any one of in this case, the category is maternal and perinatal measures. So you'd be able to look at postpartum care or the prenatal care measure that we looked like. And I will include the link to the updated dashboard in the chat, but I believe this is the last slide, maybe. Yes. So I believe that link will work, but I will also drop it in the chat so we can, folks can take a look at the updated dashboards. And we're excited to continue to provide that information to you all. Any questions on this information?
I don't see in the chat. Thank you both. I do have one regarding kind of the collapsing of the measurement of well-child visits for all children, like 3 to 20. Does that make it feels like that makes it hard to kind of target intervention where rates are particularly low? And I know from looking at past data, rates of well-child visits tend to like go down as the child gets older. And I was just kind of wondering if you had thoughts on that, or if GMS had kind of other metrics that weren't HEDIS that they were looking at to make sure all our kids across kind of the age range are getting the care and preventative services.
It is very interesting that NCQA collapsed those measures. As you said, that broadens the range very significantly for the ages that are covered in that one measure. We do still have the potential to look back at using the older specifications for those measures. Obviously, they won't be the same as the audited validated measures, but we are taking a look at the ability to look at those back on that. So the two that were collapsed were the well-child visits in the 3rd, 4th, 5th, and 6th years of life, and the adolescent well-care visit into that one super measure. So we will potentially look at still using those for internal monitoring purposes, since we have historic data to look at, and are open to further ideas and suggestions on not losing that granularity, especially since we're seeing differences in immunization rates and things that might be indicating that there are different, definitely differences in service preventative care that's being rendered.
Sorry, I've one more question. When looking at that rate, so the well child visits, I think it was somewhere like in the 60s, and some of the individual vaccines for like 13-year-olds were that one, it were also in that. Is it or do we think that folks are getting into a doctor and OBGYN but not necessarily checking all the boxes that are required for the well child visit? Or like folks are just not getting to the doctor, or they're getting care in other places? What do we think are kind of the root causes of some of that lower well child visit number? And then what, is DMAS or MCOs kind of pursuing specific interventions to try to increase them?
Well, I will say that I am not quite sure as to at this time as to what's driving some of that information. I will say that for Measure Me Year 21, we are seeing increases in these visits. So overall, I would say that we're seeing that the uptake as we're moving into a through the pandemic and into times where people feel more comfortable getting access to those services. But there also could be a potential situation of younger children and newer parents who might be slower on the uptake to that information compared to children that are older and have potentially established relationships that are moving forward. So I think what we might be seeing is potentially trying to ensure that especially newborns and newer parents and those children are receiving the care.
Thank you. Do committee members, anyone else have any questions regarding specifically COVID vaccine rates or any of the HEDIS measures that we looked at?
Hi, this is Vanessa. Just a general question. So I haven't checked out the dashboard, but to the questions that were previously raised, is there a way for us to understand when looking at the data, what actions are being driven by that data?
I would recommend, and I certainly think that this group would receive. I'll make sure that we send this along. One of the reports that are that we work in the quality and population health team is to create something called the annual technical report, which is actually basically a summary of all of the interventions that are really driving a lot that DMAS has identified that are meant to be kind of moving the needle, and some of the key measures here in HEDIS that can help sort of identify what DMAS is doing and what our MCO partners are doing. And also with that, because it's actually developed by our third-party external quality review organization, they also provide feedback and recommendations as to areas where DMAS and the MCOs taking a look at the quality activities to move forward. I would say it's not as one-to-one as looking at that dashboard and then being able to click on something and move over to all those topics, but we're hoping to make it more accessible for members to understand all of the work that is being done to move these measures forward. And I'll add a link to the annual technical reports. We've actually just updated, we not only updated the dashboard, we actually updated our quality website to try to provide a better, more centralized location for all of our studies and reports that we create from the quality and population health team to help draw those connections. And we're continuing to work on visual ways and drawing those connections. Some of these reports are pretty dense, and we really are working and really appreciate feedback on how to make them more accessible.
There's a question in the chat from Ali for Rich. I'm curious if there's a national goal or standard for youth vaccinations.
That's a great question. I personally don't know that, but I'd be happy to take note of that and reach out to our office of the chief medical officer and see what kind of information they might have, and if we can get any kind of context there.
Great. And one more question in the chat. Are we worried about these low vaccination rates leading to long-term health issues for Medicaid members? I'm seeing some research about long COVID symptoms in kids.
Sure. Not to speak for the entire agency, but I recognize that the CDC is recommending for everyone to receive their COVID vaccination in order to give them the best protection against contacting the COVID-19 virus. So yes, I recognize that the Medicaid rates do have opportunities for growth and increasing as members continue to become more informed and educated and have conversations with their providers and pediatricians. So absolutely, I'm sure that the emerging research around long COVID could factor into those conversations.
And as a bit of an aside, I'm just with the kind of very high rates of flu this year, as well as RSV for kids. Just curious if there's any data on or specific pushes for Medicaid members to get, the flu vaccine more than, I know there's annual pushes, but more so. And if there's any kind of data, I know it's early, if members are getting those.
Sure. If I don't know if Dan is still on the call or someone from one of the program teams might actually have more specific information to relay about that.
I'm sorry, I'm still on the call. Could you repeat the question?
Hey, Dan, yeah, sorry. I was just asking if there was any information about flu vaccine uptake or specific interventions DMAS is pursuing, given just the high rates of flu and the early onset of flu season this year.
Yeah, sure. So, I mean, I guess you're talking specific to the regular non-COVID influenza?
Yeah. I mean, I guess in addition to
Sure,
COVID.
sure. Yeah, that's something we can share. We can put together something and share that with you guys.
In addition, I will say just we hadn't historically presented the flu results from HEDIS to this group, but we can pull those and provide those as well for data.
Dr. Boutwell, would those be broken out by age at all, or do we have the capability to do that?
At a granular level, I would have to check to see how granular we can pull that information. Let me confirm and get back to you.
This is Michael Cook for Rich again. Rich, are we still working with the plans to get trusted community, trusted folks within the community, such as the churches, to try and increase COVID vaccination levels?
That's a great question, Mr. Cook. Dan, I'll maybe ask if you're aware. That's put you on the spot.
I'm not aware. That's something we'll have to follow up on. I'm not aware off the top of my head.
For what it's worth, especially in communities of color, that's been one of the nationwide. That's been one of the real hard pushes. Getting. It takes what they found is it takes people who are trusted within the community to really break down some of the barriers and myths that are involved. Anything we can do to push our plans, who I hope have figured that one out in that direction, would be really helpful.
Yeah, I will say that the plans especially during COVID, found that they were successful when they could find as someone within the community or the city or wherever that had a lot of exposure to the community and that the community trusted. So that certainly has been something that, you know, they have tried to use.
This is Heidi. I just, can you all hear me?
Yes.
I just want to say on behalf of the plans, I think, and Dan can also, we can get data, but I think they've also been doing a lot of that and trying to really focus on Petersburg, as you know, Michael, and efforts in that community. And they're starting to see some traction and payoff by trying to work with the organizations and individuals that already live there and know the community. So we are seeing some success with that.
Yeah, and Heidi, I mean, Petersburg is a phenomenal, is a great initiative that hopefully is going to show us a model for how to address cities that are in decay. But and I shouldn't say but, and I think that's the type of that ought to be a model elsewhere in the state. You know, folks aren't going to trust people like us to walk in and say, hey, this is a great idea, trust us. But places like the churches, like community organizations, tend to have a much better track record in that area. So thanks.
Well, if there are no more specific questions, y'all have teed up our next presentation spectacularly, so thank you. We actually have Kimberly White from Anthem Healthkeepers, who's the director of whole health, to talk a little more about their strategies to improve well visits for the population they serve and vaccination rates. So Kimberly, as you can hear, we're very excited to learn what you're doing and what's working, and we really just appreciate you taking your time out to come talk with us today. So thank you so much.
Thanks. I'm really happy to be here. And I will address what we are doing from Anthem perspective toward the end of this. So Michael, hopefully that will be helpful. And I will say the other health plans are also definitely taking some very targeted strategic approaches, even outside of just Petersburg. We're specifically seeing, you know, a lot of health disparities, especially with the vaccination rates, as has already been showed in far Southwest Virginia. So I know a lot of focus is also in going there, but I can touch on that more toward the end, and hopefully that can help. All right, well, thank you. As Sarah had said, I am the director of whole health. I oversee our population health strategy at the Anthem Virginia Medicaid Health Plan. So I'm going to just go over just some high-level data, just specific, some nationally and some specific to Virginia around vaccination rates, and then talk around strategy toward the end. Next slide. So all of these slides, when there is data, there will be a live link that you can access should you want to dig into it a little bit more. This was specific from VDH, and it has some really good data in it. And actually, it's even changed since we initially did this particular, or submitted this presentation. When I've looked at it recently, because it does have the 2022 fall immunization rates now included. So this is specifically a look at just Virginia immunization in kindergartners. And so, you know, there's a lot of vaccinations that we want our young kiddos to get when they're starting school, specifically the DTaP, polio, MMR, chickenpox. You can see on this slide that it shows the lighter areas where they have less of the kids vaccinated and the kindergarten grade, and then the darker where they have more of the vaccination rate compliance. So we're overall 88.6% for the kindergartners across the state, and actually the most recent data went up to 89.3%. When it included that fall of 2022. So we're really, you know, we're working, at least moving in the right direction. And if you do decide to go actually onto the site, you can even click on the various areas and it will pull up the particular schools and even give what their particular data is. So it was pretty insightful to see. Next slide. So this is specific for 7th grade. So in 7th grade, you have the Tdap, Hep B, MMR, and HPV, and the meningococcal or the meningitis. And so you see overall, we have, pretty decent rates in Virginia. At this grade, we, in our school systems, they are reporting in at 86.5%, and that actually is now, with the most recent data, at 91.3%. So again, moving in the right direction. I will say, and this is going to be a theme throughout that you will see, is that typically the lowest as we move up toward the age groups, the grades, is HPV, and also that second dose of the meningitis. But just wanted to kind of flag that. Next slide. And this is 12th grade. 12th grade is really focusing on that meningitis and that HPV. You can see that the rates are kind of going down a little bit, which is very typical for our children. As all of you know, typically as our children get older, those vaccination rates tend to decline. You can see that, one of the lowest areas is only at 23.1% specifically. And again, this is because that second dose of that meningitis and the HPV are historically much lower than any other vaccinations like the MMR and polio and such. Next slide. So this was just a look specific again to Virginia data, and it goes back from 2009 to 2020. And the real piece to highlight here is you can see the religious exemptions, which are in green, the medical is the striped blue, and overall you can just see an increased trend in the religious exemptions. And actually from that 4-year block from 2017 to 2020, you see that it's remained fairly high and at that higher rate without a whole lot of dipping. As it was in previous years. So just something that's kind of interesting. It'll be interesting to see how, the effects of COVID as we move through, tracking to 2021 and 2022 also may, or may not influence that. Next slide. So this is nationwide data, but we really wanted to show just the broader view in adolescents in those key vaccination rates for the 13 to 17 year population. And I know it's really small and I apologize, but basically it does represent the white, Black, Hispanic, the Native American, and Asian and Pacific Islander on this. And just the couple pieces that I wanted to point out is where you see the orange, where it's dipping the lowest. Again, and I've said this consistently, that is that second vaccination for the meningitis, and that is specific to other races, and that just didn't, that just were self-identifying as other. So there could be a lot into that category. And then you also see white is the lowest, specifically in the HPV, that second dose. Also, interestingly, is you see the darker green, that is actually an Asian population, and they are the highest across the board nationwide in vaccination rates. Next slide. And this was really interesting, again, nationwide data, but it was just really interesting to look at the vaccination rates in that 13 to 17 year population, but specific to health insurance coverage. Again, I know it's really small, but what you have here is you have the private insurance that's in the blue, you have Medicaid that's in red, the other insurance is in that kind of lighter green color, and then the dark blue is the uninsured. Of interest was really that green, that dip that was specific for that second dose of the meningitis. And what is included in other insurance includes military and includes CHIP specifically. The other piece that you can see is very low, which may not be completely surprising, but is that second in the HPV, the second dose for HPV and the uninsured. Next slide. The immunizations year over year for 6th to 7th grade. This was just something that was interesting. This is again now going back to Virginia specific data, and I just really want to hone in on the private and the public school. You see the private is in green, and then you see the public school vaccination rates are in the red. And overall, other than the bump in 2019, you do see that public school settings have higher vaccination rates specifically for kids. And this is 6th and 7th graders. Next slide. So this really broke it down for 7th grade, and this was more recent data from 2022, and it broke it down by the vaccination. And you can see the public that is in the light blue, the private, or I'm sorry, the public that's in the striped, and the public that's in the striped, the private that is in the dark blue, and then just the combined average, which is in the light blue. So overall, you can see it seems pretty even across the board when you're looking at it specifically by the vaccination type in 2020 for 7th grade. However, you do definitely see for any public or private schooling or combined that definitely that meningitis vaccination, which is that MCV one right there, is lower than any of the others. And then you see a significant dip in the HPV for private schools, which was interesting. Next slide. Again, I'm so sorry that it's so small. So hopefully you could see the deck and you can make it bigger after this presentation. But what this really is showing is specific for HPV. We really wanted to dive into that a little bit more to figure out what's really around that. And so this shows a comparison of the United States versus Virginia. So on the left, you see the United States. That red line is females, the green is males, and then the orange is just the combined. And this goes back all the way from, it's hard for me to even say, I think 2008 to 2021, I believe. And so this is really, interesting because you see a great trend and upward movement, both in the United States. And then if you look over to our Virginia data, you see the same, which is really great. The other piece that you can see is that the uptick of males getting it, which often had really not been the case in the beginning of that particular vaccination. You do notice a little dip though in our data, which is the second one, with males specifically more recently. And so that's the only piece that was a little concerning. Hopefully we won't continue to see that downward trend. Next slide. All right, so this is overall for the particular vaccinations. This is actually the Virginia versus United States. And so this is really interesting because each of these figures here represents a specific vaccination, from MMR to DTaP to polio to Hep B. And so the light is the light blue is United States, and the dark is Virginia specifically. And one thing I want to point out is even in some of these where you see we're way below, or like in polio and Hep B, these are all still fairly high vaccination rates overall. I mean, they're all in the 90 or above percentiles. But one of the things that we found really interesting is that you see this big dip between 2021 and 2022 from a national perspective in the vaccination rates, which may not necessarily be completely unheard of. There was a lot, we were shut down. There was a lot of, well visits not happening, just for everybody across the board, and especially for our children. But you did not see that trend specific to the Virginia data. So I thought that was really interesting and really promising. So next slide. And this, I do not need to necessarily belabor, but I didn't want to not mention, obviously, what we've all been talking about the most, which is COVID, and how it really has shown the huge health inequities that we have within our healthcare system and overall wellness within our various populations. This is just a tiny little snapshot. This doesn't give, obviously, all of the various pictures of everything that I think came to bear with COVID. Not to even mention, as Cheryl kind of said in the beginning, you know, the behavioral health crisis that we have as well on our hands. But the health disparities, you know, by race, and I would even say, you know, regionally, we really came to bear even more so than ever. That first figure is simply just a small snapshot of cases in children by race. These are just the cases, and they were just in that specific day. And it's so clear that you can see, you know, Black, Hispanic, your American Indian, your Pacific Islanders. I mean, had absolutely many more cases often than other races. And then you notice this even more so when you start looking at that next figure beside it, which is showing the hospitalizations. Again, this is nothing new. We've all seen this really sad data, you know, year over year. But this one is even more, you know, more shocking when you just look at how, you know, you have Black, you have Hispanic, you have your American Indian, and your Pacific Islanders, who all are significantly higher in hospitalizations as compared to Asian and white. And then sadly for the deaths, which is the figure below the above one, it's the same. Definitely within the Black, Hispanic, and American Indian populations, you have significantly more deaths than you do in your Asian and white populations. Next slide. So what are some of the barriers? And I know we're all very privy to a lot of the barriers. You know, access is huge. You know, one of the great things with the COVID vaccination is we definitely have a lot of access to it, and it's great. And we can simply go to pharmacies and get it, which is wonderful. There's definitely, COVID has brought to bear a significant healthcare workforce issue now that still is among us and may remain for quite some time. And there is some access issues, just even getting appointments in to pediatricians and PCPs. I know personally, I attempted to my daughter to get a well visit with her pediatrician who she's been with for years, and I could not, or I think I had to wait like 3 months. They're just inundated. They don't have enough staff. A lot of the offices have closed, especially more rural areas. And unless you have right now as a kid symptoms of RSV, COVID, or influenza, they're basically like, you know, you're going to have to wait. So there is some access issues that I do hope that workforce will hopefully, you know, broaden over time. Transportation, fortunately for Medicaid recipients, it is a covered benefit for all of the health plans. So within the contracts with DMS. And so, you know, we're really excited about that because obviously transportation is key to get the access that you need. And we all know, you know, Southwest Virginia does not have a public transportation system. And you can travel, you know, hours sometimes, especially if you need to get to some, you know, to sometimes appointments and especially specialists. So transportation is key. I will say COVID also really hit that industry hard as well. There are often not a whole lot of non-emergency medical transportation providers, at least as compared to pre-COVID. So that's also, you know, going to be a continued barrier for some time from a workforce perspective. And then, of course, we all know all too well misinformation that raised its kind of ugly head absolutely during COVID. And that still goes into vaccinations even outside of COVID, though. One of the ones that we really dug into was around HPV, because you saw that was consistently so low. And I don't have this data as part of the slide deck, but the National Cancer Institute actually has that in 2015, it was 13% of parents declined to get that vaccination for their child because of safety concerns. And that actually jumped in 2018 to 23% who declined because of safety concerns, when actually there is no evidence that there are any significant safety concerns outside from the very, you know, remote allergic reactions that really all vaccinations have. And so that was really interesting. The second reason that a lot of parents stated that they did not get their child the HPV vaccination is because they simply stated that they didn't know anything about it. And so, just as a healthcare system in general, it seems like we probably have some work to do around just basic education around that and what it prevents and why it's important. And then another interesting piece was that parents were often hesitant, thinking that it would promote sexual activity. And so again, I think just getting some more education around that and what statistics really say, I think could probably be helpful. And then, I won't belabor the consequences. I think we're living and breathing it literally. I think we know what the consequences are when we don't get the necessary vaccinations, for ourselves, for our families, for our neighborhoods, and our communities at large. So, yeah, we definitely have come to realize the importance of that. Next slide. So what are we doing to really affect, change and really increasing, these rates? So you heard the presentation earlier around HEDIS gaps in care. So all of the health plans, not just Anthem, are really held to making sure that we are improving upon those HEDIS gaps in care, making sure that we are focusing on well visits for our children, making sure that they're getting those vaccinations and those preventative appointments. So we do a lot around that. All of our care coordinators are trained in the HEDIS gaps. Our systems have flags when we have children and actually all of our members, adults as well, when there's HEDIS gaps. We even have some flags in our systems, our other systems, our emergency department system that will also notify us when there's particular gaps. We do texting campaigns around them. We have mailings, birthday reminders around child visits. We do an age out immunization outreach. And so that's when a child hasn't been immunized in that age group period where it's recommended that they have that particular series of vaccinations. And then we're doing a lot of work, even more so just recently. We've been having some meetings here at Anthem with a lot of the DSS offices, and actually just spoke with some of the other MCOs at the CSA conference, but really trying to work to partner with our foster care members to make sure that we help the DSS workers and guardians to really get those doctor's appointments in within that 60 days of enrollment into the foster care system, because that is part of the requirement and it's often very hard. Like I gave you the example of my example of the pediatrician for my daughter appointment. It can be hard. So the managed care organizations, I know, and it work really hard to try to partner with DSSs. And so at Anthem, we're really trying to do a lot around that. Next slide. We also have a lot of provider incentives, and I won't go through all of these in detail, but we do have what we call Provider Quality Incentive Program, and essentially that PQIP for short, and essentially that is where we incent providers to specifically hone in on ensuring that those HEDIS measures measures are getting taken care of, and if there's gaps that we are closing them. So you can see some of those examples of some of the measures that we incentivize with our providers: the childhood immunizations, the child and adolescent well care visits, and then that combo for the immunizations for the adolescents. The other piece that I really wanted to hone in on is how we really are partnering within our communities. So I think, Michael, this is what really gets at to, I think, what you were saying. So specific to COVID, we did a lot specifically around COVID, and actually I know all of the MCOs worked really hard in conjunction with DMAS to really figure out, okay, how are we going to partner to outreach? We did a couple of different waves. I would say in the first wave, it was really just telephonic outreach, trying to call as many people as we can, letting them know that vaccinations are now available, because obviously in the beginning they often weren't. letting them know that it was covered, that they don't need to pay, you know, so on and so forth. We also then partnered with particular FQHCs to have clinic days where we would just have, you know, just advertise, basically show up here in this particular locality, and, you know, we'll help you to get a quick appointment to get those vaccinations. So we did a lot around that. So after we got through kind of that group, those were the ones that were willing, right, to get the vaccination. They kind of needed maybe more access or maybe just some reminders and education around it. Then we really had to move to the areas that we had a lot more vaccination hesitancy. And that's definitely been harder. We have partnered with churches, especially we partnered with a larger church out in far Southwest Virginia, really trying to figure out how we can, to your point, partner with trusted people that they really know and interact with regularly and are part of their community. I think we had some success with that, I think, early on, but what we did find, at least from Anthem's perspective, what we found was as we moved further into the pandemic, that subpopulation that was hesitant, it was just almost no matter what anybody was going to do, that was where they were going to remain. So we found that it was much harder to move the needle as we kind of went further into the pandemic. I saw about schools. So with schools, yes, we are planning on continuing to partner with schools, but we did specifically partner with the schools in Petersburg. Anthem had recently sponsored a vaccination day. We kind of try to get the word out with partnering with some CBOs and a local radio station to get the word out, because we found that there was, I can't remember the number now, and this was in partnership, of course, with DMAS around this and around the governor's initiatives, but there was kiddos that just weren't going to school, and because they had not gotten vaccinated. So we set up, kind of a mobile clinic of sorts with the help of a provider to help with that, and working in the schools is going to have to be a really key strategy, especially in those areas. I keep mentioning far Southwest, but of course there's many others, but where there's a lot of just maybe lack of education or just lack of access in the transportation. So yes, we are definitely continuing to partner with the schools. We have not done anything specific, at least Anthem has not done anything yet specific with childcare centers, but that's definitely something that we can also try to tap into for sure. I will stop there and see if there are any questions. I can't remember exactly how much time I had. So.
Hi, my name is Vanessa Walker-Harris. I work at Department of Health. Thank you so much for this very helpful presentation. I did have a question about whether you partnered with the local health district for any of the school-based clinics, and any suggestions you have on making sure public health is leveraging your resources and you all are leveraging our resources to increase access to immunizations for kids.
Yeah, I can't speak to any specific partnership that we did with the school systems. A lot of what we utilized was our existing relationships within the communities with our school systems. But Vanessa, to your point, I mean, we definitely have to, I think, have more of a partnership, shared data, so we can really have a more targeted focus from a population health strategy. I do think sometimes, we're very, we're all very matrixed, and we kind of stay sort of in our bubbles and just kind of, maybe don't always leverage what we all can bring to bear together. So I really do think that's a good call out, and I think that we need to do more of that as we really work on all the things that we're really focused on from a whole health, population health strategy for Virginia.
There,
Kimberly, this is Kelly. Oh, I had one question. Thank you.
yeah, go for
Hey,
Kelly. I was
Kimberly,
gonna,
yeah, prompt that. Thank you for talking about the barriers as well as all the outreach efforts that you're doing to improve vaccination and preventative services. I had a specific question that was related to the current flu and respiratory illness situation that children are facing in the Commonwealth. We're seeing pocketed shortages of specific medications like amoxicillin and Tamiflu specifically, and the parental workarounds are spending 4+ hours on the phone calling every pharmacy in your region and trying to track that down, which I think we can recognize is probably really difficult for members. I was curious how your care coordinators might be able to step in when there's diagnoses of flu, strep, or other common illnesses that might require those medications and how they could assist them.
Oh, yeah, that's a great question. And actually, thank you for bringing that to bear because I don't think, well, I know I was not actually aware of that. But it makes sense given what all of our kids are going through right now with influenza and RSV and everything. Yes, our care coordinators can absolutely help. And this is, of course, not just Anthem specific. I mean, this is all of our MCOs, right, that participate in these 2 contracts. And so, you know, so for Anthem anyway, we have a member services line. So any member, and it doesn't matter whether they're right now on the CCC Plus or if they're in the medallion product, that they would then be able to get any referrals specifically that may include help with some pharmacy. However, I will say more than likely that's going to have to be transitioned to our clinical team, our care coordinators, which, you know, that is exactly what they're there for. And they will work with the parent, you know, the member, whomever the guardian is, to call pharmacies to figure out what we can do. That is exactly what DMAS is. That's what DMAS is asking us to do from a care coordination perspective. And so that's actually what we should be doing. So that's really good for us to know. But please, if you guys anybody on the call can socialize that and just make sure that everybody knows when they're having that type of struggle in anything pharmacy related, the care coordinators can actually, or that's part of their job. Yep. And if they don't have an assigned care coordinator, I do want to just say this really quick. If they don't have an assigned care coordinator, because in the medallion product where a lot of our kiddos are, they may not, we can get them an assigned care coordinator very easily. So that's also not a problem.
there's just a couple of questions in the chat. So just about partnering with schools or childcare facilities and the efficacy of kind of giving gift cards for folks when they get vaccinated.
Yeah, so, you know, I don't know the data on the, I think I answered the childcare one, but in the school one, but as far as the MCOs giving the gift cards, yeah, I mean, we were trying everything and anything. A matter of fact, we worked with DMAX very closely. I mean, Dan was on a lot of these calls. It was Cheryl, where in all the MCOs, and we were like, what on earth can we try to do to really move this needle? And so, yeah, a lot of them, we did do the gift cards. Of course, we were, you know, limited, you know, by contract about how much you could give, and there's all those parameters, you know, but I don't know if we have any data on how effective that really was. We were kind of just throwing everything at the time at the kitchen sink to try to get as many people vaccinated as possible. We were working hours and hours and hours, even into the evening, a lot of our care coordinators into doing this. So, you know, that would be interesting to know. And I'm going to actually go back to see if we have anything on that. And I'm even curious if we didn't collect that data, do we have, you know, other MCOs that also collected that data? But yeah, that's a really good question. I just unfortunately don't have the answer to it.
Great. So just gonna make one last call for member questions. Well, Kimberly, I just want to say thank you so much for sharing all of this data and so much to think about. And hopefully members can, you know, help use this data, have this data help you think about recommendations for procurement and how we can recommend kind of innovative strategies going forward as our MCO program continues to develop in Virginia. So thank you again for your time. And one last call. I don't see anything else coming through. Anyone else coming off mute. So thank you so much. And we're
Thanks, I
gonna
appreciate it.
absolutely. We will now turn to some maternal health updates. So we just are, again, kind of following up on some things that we had touched on earlier in the year. And folks had expressed some interest in learning some more about it and learning how things are going as these programs are getting implemented. So first, we're going to hear about the doula benefit. And I know we have at least a handful of Medicaid babies who have been born with the help of a doula. So excited to hear how that program is continue to grow and become operationalized. And then we're also going to hear just a little more of a from Virginia Premier about some of their maternal health child programs. So I will turn it over to the DMAS folks to talk about doula services. Thank you so much.
Great, thank you so much. Well, thank you, everyone. Good afternoon. My name's Natasha Turner. I am the doula program analyst in the healthcare services division in the maternal child care unit. And today I'll just be sharing some updates, as Sarah mentioned, with you on the implementation of the Virginia Medicaid doula benefit. Next slide, please. So to begin, just to kind of touch on what we're saying when we are talking about community doulas. And so a community doula is really a non-medical professional who provides continuous physical, emotional, and informational support to pregnant women prenatally, throughout pregnancy, during labor and delivery, and in the postpartum period. Community doulas serve families often in under-resourced communities. Community doulas focus on health equity and the social determinants of health. And they also provide referrals and connections to critical community resources such as transportation, food, housing assistance, or other supports that members in the community or pregnant members may need. Community doulas also partner with the birthing parents and their medical care team, often to facilitate communication and help members really feel empowered to navigate their medical care and make choices that align with their birthing plan. Next slide, please. So research has shown that pregnant individuals who receive doula care are more likely to have a healthy birth outcome and a positive birth experience. We know that studies have shown that doula care and doula services may increase the likelihood of a vaginal birth, may increase contribute to a higher 5-minute newborn APGAR score, and increase the likelihood of breastfeeding initiation. Likewise, we know that research has shown that doula care and doula services may reduce delivery by cesarean section, reduce the use of epidural pain relief, and reduce preterm births and instrument-assisted births. Next slide, please. So when we're talking about the Medicaid doula benefit, this benefit provides for 4 prenatal visits, 4 postpartum visits, attendance during labor and delivery, and it also, in our effort to really strengthen our collective efforts to ensure mom and baby receive the necessary follow-up care that we know is so important in the postpartum period, there are 2 what we call linkage to care incentives. And those are 2 additional cash incentives. One incentive payment can be received by the doula if the member attends the postpartum follow-up with their OBGYN. And then the second incentive payment can be received by the doula if the newborn attends the well baby visit following birth. Next slide, please. So since our last update in June, as Sarah mentioned, there have been births, but our program has doubled the number of state-certified community doulas. So in June, we reported that there were 31. So if you kind of look at the slide here, we have blue, and those are kind of the things that we were reporting in June. And then everything in red to the right is kind of the new stuff. So that's really exciting. So in June, we had 31 state-certified community doulas. And today, there are 65 state-certified community community doulas, which have met the training and education qualifications through the Virginia Certification Board. In May, we mentioned that Medicaid had enrolled the first state certified community doula as a Medicaid provider. We were really super excited about that. And today there are 37 Medicaid doula providers, which are contracted with our healthcare plans and have begun providing doula services and supports to our Medicaid members. So we are super excited about that. In August, we had our first Medicaid members receive doula services. And in October, Virginia Medicaid had its first 4 doula supported births. So today, we are excited to say that the Community Doula Program has over 90 Medicaid members right now receiving doula services. There are 10 babies that have been born with the support of a Medicaid doula provider, and the members have reported satisfaction with having the support of a doula and receiving doula services. And really, the members that have given birth have also continued with their postpartum doula visits, which provide that much needed support and encouragement that new parents need following birth. Next slide, please. And you can go on to the next one. So looking ahead, the program is continuing to build. Probably the key piece of all this, or one of the most important pieces, is that network of Medicaid doula providers. The program is also focusing on building a strategic plan, which focuses on 3 goal areas. So the first one, infrastructure and support, which includes really the engaging the doulas, building and sustaining that network of doula providers. And so all the activities that go along with that. And then the second goal area is really focus on collaboration, partnership, and buy-in. The support, with the emphasis on partner engagement of our MCOs, our state agencies, medical providers, our community stakeholders. Also, this is the area where we're doing some of those toolkit and website development. We have our website, which is toward the end of this presentation, that you can go and see for more information on the program, but where our communications, our medical provider or licensed provider training, and also that ongoing engagement with the doulas, which is really key. We're continuing our quarterly community doula meeting and the Virginia Task Force meetings as well. And then I have to just pause here just to say that all 6 health plans have really been supportive and engaged in this program, in the planning and the implementation efforts. They continue to be really engaged, really supportive with training. Many have provided scholarships or funding for doula training and even conducted outreach within their networks. They have been great in streamlining some of their processes for the doulas to make things much easier for them, because they are new providers, they are new to Medicaid, and this is a new benefit. So they have really been great. And finally, our last area is really an outcome evaluation and sustainability. So really beginning to look at exploring the data and the outcomes, both the health outcomes for our members and their babies, but also the program outcomes, to look at ways of measuring success for the community doula program. It takes all of us working together to make this program successful. So I'm really happy to share just some of our progress over the last couple of months. Next slide. And I really wanted to leave you with just an introduction of two of our first Medicaid community doulas. The first Medicaid doula is Sequoia Phipps Hawkins. She's a doula with Birth in Color, RVA. She's a doula that comes into our network as a doula that's affiliated with a doula organization. And then Larissa Joes at the bottom here is an individual doula. So doulas can come in affiliated with doula organizations, or they can come into the Medicaid provider network as just individual doulas providing doula services to our members. And so they've shared with us a little bit of their passion, a little bit of their why, and why they got involved in this work, why they're doing this work, and what it means to them. So next slide, please. So I just wanted to thank you for your time today. Our website is there at the bottom. And I will just make a mention that one other exciting thing that happened, we have just finalized just this week 2 provider engagement videos that were just finalized that are going to be used for education and engagement, not only for the doulas, but also for our licensed provider community. So those will be coming soon, so stay tuned. And that's all I have.
Thank you so much. Again, just such great information. I don't know if members want to pause for questions now, or if we can turn it over to the next speaker and then kind of do questions all at the end. Not hearing anything urgent. We'll turn it over to Chantel Niche. She's the Director of Social Determinants of Health and Member Outreach and Community Development at Virginia Premier for the Maternal and Child Health Program. So thank you.
Sarah, sorry to interrupt. We have one more DMAS presentation.
I'm sorry, one more.
So we're
gonna the agenda. Thanks, Hope.
No problem. So we're gonna have Marissa Sadler. Are you on the call, Marissa?
I am. Thank you, Hope, and thank you, Sarah. No worries about that. And thank you,
Thanks
Natasha.
To me, but thank you for coming.
Thank you, Natasha, for kicking that off. And this is just going to bring it home as to what we're doing with Virginia Medicaid in regards to maternal health. And so my name is Marissa Sadler, and I'm Maternal and Women's Health Operations Analyst here. And I'm just going to go over some of the projects and initiatives that we currently have in place in an effort to support our parenting and postpartum members here at DMAS. Next slide, please. Thank you. And so Virginia Medicaid, we have strived continuously, even before I was here, to address our pregnant and parenting members, and specifically through the doula project and through postpartum. And so in 2019, DMAS decided we need to have some type of initiative, or not necessarily a program, but something to talk about our maternal facing projects to bring awareness to our pregnant and parenting members, both Medicaid and for FAMUS. And so within that, we developed Baby Steps Virginia. And some of you all who are on this call may also be a part of that, our bi-monthly meetings that we have. So we've done some amazing things since 2019 and continuing to address our providers and our members as well. But within that, we have 5 focus areas, as you can see here, within eligibility and enrollment, outreach and information, connections, new and improved services and policies, and also oversight. And a lot of these focus areas here both coincide together as we continue to work with our providers and our members, and that a lot of that impact also comes from our MCOs, who have been a huge lift in supporting us throughout this different initiatives and projects that we have currently in place. And also we partner with our sister agencies. Next slide, please. Thank you. And specifically with that, this is actually our 2nd year of being awarded or work to be able to work with NASHP, which is our National Academy for State Health Policy, within their maternal child health policy initiative program. And within that, last year we were able to work with pregnant women within the substance use disorder, so SUD awareness with that. And for this year, we're going to be closing out March 2023, in which we have worked with maternal mortality and racial disparities, which all align with Baby Steps Virginia, and then with past Governor Northam and also Governor Youngkin of working with pregnant and postpartum members. So this has been a great lift and a lot of great work that we have done thus far. And so below you'll see pictured here, we were able to go to the NASHP conference in Seattle this past September to present on some of the work that we're doing with the PIP. And so it was such a beautiful experience to get to work with others and to hear what the other states are doing to address racial disparities in maternal mortality. So next slide, please. Thank you. And so within the NASHP PIP, we were tasked to think of different areas we want to work in within our specific state. So Virginia, what do we want to do? And so what not a great way to talk about postpartum coverage, as Dan talked about, is a new initiative for this year, and also community doula implementation. So for postpartum coverage, we are the third state to be awarded that within CMS, to go from 60 days postpartum coverage to now 12 months for moms to have that coverage, which is super imperative and important for moms as we continue to address these different health outcomes. And also the fourth state, as you heard from Natasha, to be awarded for Virginia Medicaid, to do Medicaid for community doulas. So this is such a great step. And so we've decided to work within this realm or this area for maternal health, excuse me. And so within these two focus areas for PIP, we decided to focus on, of course, member and provider outreach and how can we improve these outcomes, and to make more awareness of this new policy that is in place. And so we've worked together with two of our MCOs, also other sister agencies such as VDH and VMPC to assist us with this, to kind of think of ways to increase awareness and communication for both members and providers. And so developing a toolkit is something that we have also been working with, to bring awareness of maternal mental health, breastfeeding, and postpartum and delivery, just some of the two that we're doing, and also a flyer for providers to bring awareness. And so thinking about different ways of dissemination, such as social media. We're really good at using our platforms here at DMAS, such as Instagram and Facebook, and also think of different avenues such as YouTube. And so currently within our community doula implementation, we've worked with Natasha and other groups within that area to think about the different knowledge and resources that would be beneficial for members and also for doulas to understand what that looks like and what that impact looks like and see what the importance is of having a doula. And so in order for us to kind of get that message out there, we understand that our MCOs are going to be a big participant in that to get that lift and bring awareness to our members and providers. So what does that knowledge look like? And also what resources are available for our members. So we understand that social determinants of health are a big issue, and there are several areas of access to barriers for our Medicaid pregnant and parenting women. So what about transportation in order for you to get to those appointments? And so we're kind of bring it around full circle as to what Baby Steps Virginia is all about and the different projects and initiatives that we're working on. We understand that we can still address each of these focus areas with all our projects. Next slide, please. And as I said before, postpartum outreach and communication here is just a brief example of one of the one-pagers that we are in the midst of creating and finalizing for our providers to talk about some of the high-level pieces, not all the pieces, but very high level that we want the provider to understand and what that benefit looks like, and also the development of other one-pagers for members. So I think as we continue to work with our MCOs, our sister agencies, although this is not new, but it's still a new benefit as of July 1st. We want to continue to get that word out so that there are no unanswered questions, and developing different memos and bulletins and frequently asked question documents, so that members and providers, since providers are the first line of communication for our members next to our care coordinators, as to what that looks like and what benefits are available for them. So we've done some great work, and we'll continue to do this well beyond the end of the PIP, as I stated, which ends March 2023. But we'll continue to address this as long as it's falling within our Baby Steps Virginia 5 focus areas, and continue to address the health outcomes and improve those outcomes for our pregnant and parenting women. Next slide. Thank you. And so that'll close it out for me. And as Sarah said, if there are any other questions as far as doulas are concerned or some of the work that we're doing with maternal health here at DMAS, we're happy to answer those questions now. My contact information is also here, and any other general questions you may have, you can also send those to Baby Steps Virginia at DMAS. So thank you.
I don't. What division is Baby Steps a part of? Is one question that just came into the chat.
Within our maternal child health division.
Yeah.
Within healthcare services, excuse me. Yeah.
Awesome. Well, thank you again for coming today. And I think with that, we can now finally turn it over to Chantel Neves of Virginia Premier.
Thank you so much, Sarah and Marissa. I owe you an apology, as well as the group today, because as you will find, anything that I'm associated with is long-winded in some cases for no real reason. So when I thought I had a little bit of extra time, I was really jumping at the bait to give you that additional time and information. So again, thank you so much for having me today. My name is Chantel Neves. I am from Virginia Premier, and again, have the longest title in managed care. I believe I am the Director for Member Outreach, Social Determinants of Health, and Community Development. And within that existing structure, we have our maternal child health outreach program. So we can move to the next slide. I'll try to start with a very 10,000-foot view and sprinkle in some details as we move through the remainder of the presentation. But I really wanted to highlight how we have the opportunity to really take a look at how our programs are structured and how we really have the opportunity to have a level of stratification within our approach to maternal and child health initiatives. We have first our Healthy Heartbeats organization that falls really within, again, that outreach, as I mentioned. They are going to be the individuals who manage those folks who are considered low risk in their pregnancy. And with that comes the preliminary outreach when we get our files from, whether it's from DMS, whether it's from a claims report, whether it's self-reported. These are the folks that are going to make those initial phone calls to our moms and start them down that trajectory of true managed care collaboration. I'll talk a little bit more about that as we move forward. If during the homegrown assessment period we find that a mom is indeed falling into that high risk category, we take a collaborative approach to ensure that we engage our high risk OB case management team. And they are a team of RNs and social workers who really have that additional knowledge to help support the members who may have, again, some of those things that make them high risk, whether it was a prior pregnancy that was considered high risk, substance use disorder, any other one of those, and that's just a couple examples, any confounding medical conditions, any of those things that may put them in that high risk category, they would start that level of engagement. And we also take a real look at our Watch Me Grow program as another intervention to help from the child health perspective. And that really allows us to have a continuum of care from when moms engage with our programs to that postpartum period on to then starting to say, how are we ensuring that your new baby, as well as other children in the household, remain connected with managed care and also medical services, social services as well. So we'll talk a bit about that. I always have my acronyms here and always twist the letters around. So for our early periodic screening and diagnosis testing and treatments, we take a look at those components as well and ensure that we have some carved out interventions to address those EPSTD services. And I'm not sure who alluded to this. I think I was coming onto the call when someone mentioned, have the MCOs truly figured out the importance of having community-based organizations, faith leaders, a part of our plans and programs, and we have absolutely figured that out. We rely on those established relationships with trusted entities in the community to help support us through those processes and dynamics. So with that, I will go on to the next slide here and start to talk a little bit about some of the interventions that exist in among the programs that I just talked about. So as we start to look into our maternal health and start to get those folks into the plan, we do take a look at several data sources. So our goal, of course, is to identify a pregnant woman as early as possible in the pregnancy, because we know the earlier that we can identify, the greater opportunity we have to make an impact on that care and that birth outcome. So we look at a collection of files, and I mentioned some of these, but we have the DMAS file, claims reports. We utilize some of the system pieces that may come from our other health systems, or individuals who've had, say they come into the ER and they're like, all right, I've been nauseous and here we are, and now I've had some HCGs done and I am indeed pregnant. We will take a look at some of those. We have an OB registration process, which is another sort of incentivized opportunity for our providers should one identify a member as pregnant and they want to get that information back to the MCO. We have that kind of bi-directional communication with our providers in network. We have within our Healthy Heartbeats program some additional emails and touch points that we also have and allow members to contact us. So all of that, just great opportunities for us to collect data on members who have either self-identified or through some other mechanism as pregnant. We do have 17 individuals dedicated to this Healthy Heartbeats low risk, so to speak, outreach program. Each of these individuals are certified community health workers, and that really gives them an added benefit, an added edge, I do feel. They have gone through additional training to become certified, and as they go through some of the screenings and questions, they are listening very closely and astutely to see if there may be additional considerations that are impacting that pregnancy. Did this response seem as though maybe there's a little more to the story? So not only are they utilizing those skills, but they're reviewing the benefits available to mom, to include that remarkable 12-month postpartum Medicaid coverage. We look at social determinants of health as a part of that inquiry as well, just to ensure, are you, not only do you need assistance with scheduling an appointment, can you get to an appointment? Do you have the food that you need to be healthy so that you can continue to have the great development as you kind of bake on 450 for the next 9 months? So again, ensuring that we have that present and provide that level of assessment. We also ensure that we weave in some of the behavioral health components as well, because we cannot forget how important mental health is during this process, not only in the prenatal, but also the postpartum period. So there's those things that may show up and impacts under really being under new life circumstances. Breastfeeding, safe sleep, maternal fetal safety. So if we have to get a mom to maternal fetal medicine to get a little more really close follow-up from moms who may be at higher risk. We follow some of those trajectories that are laid out for us based on ACOG guidelines. So very much have a program that's embedded in those evidence-based practices. Next slide, please. And so within that, really talked about the low risk, started down the trajectory of talking about the incentive-based piece, and I think that came up when we were talking a bit about immunizations. Our Healthy Heartbeats program is an incentive-based program in itself, starting out at that prenatal period, again, with a goal that we want to ensure that when the member gets onto the plan, that they have that prenatal visit or up to 42 days post getting onto the plan. We ensure that they are routed to the appropriate community-based or even governmental regulatory resources, whether it's WIC, SNAP, other community-based resources that may be available. So ensuring that we have that connection present. We follow through the postpartum period and help answer questions that may be present regarding signing baby up for Medicaid. And as we kind of move into this postpartum period and leverage on this line of postpartum in our Watch Me Grow program, we perform a health screening not only on the child that was just delivered, but all of the planned children who are in the home. So this again gives us another opportunity to talk about some of those well child visits, thinking about immunizations, things of that nature. So again, another opportunity for us to catch a full and cast a wide net and get those folks in and engaged with the plan. We also, of course, as appropriate, talk about long-acting reversible contraception because as we go through some of our maternal health pathways, we know that a part of our goal is for folks who don't want to get pregnant, that we offer them services and education that would prevent them from being pregnant. So again, trying to really have that full spectrum as a part of the education and discussion that we have. And of course, I mentioned how we route to our high risk and ensure that we have that team available for individuals who may present as high risk. Next slide, please. And I'm going to pick it up a bit so I don't have you all here until 6 o'clock. And so as we start to look at some of the additional initiatives and other interventions that we have in place, we of course do within this Healthy Heartbeats program, as well as our case management team, conduct monthly outreach, allow that level of consistent support. Individuals and members can reach out to us via phone, via email. We send letters. We send out a packet for our program so that they have multiple areas and touch points to establish that really solid rapport and relationship. We have baby showers at a regular cadence to ensure, again, not only are we hosting from a Virginia Premier perspective, we invite individuals from the community to be a part of our baby showers to, again, show that we have not only this real focus on our members, but that we have that focus on ensuring that we have the relationships with those providing care. In that, we also have some additional preferred partnerships, which have served as a best practice for us, ensuring that we have resources available for breast and chest feeding. And within that, and I'll talk a little bit about this in the next slide, we do address and try to have some additional interventions in place for individuals who may fall into some healthcare disparities, groups and populations. We try to ensure that we have those relationships in place as well. Our teams will go out and do home visits to conduct assessments if there are concerns and someone's unable to contact. And that's not just from a health plan perspective. Say an OB has an appointment scheduled with a mom. This mom is considered high risk and they didn't show. They can reach out to us and we'll do a home visit to ensure that that member is indeed safe and try to help them get to their appointment, do a bit of a little bit of diagnostic, so to speak, or assessment to see if there are things that we can help with to get them to their appointment. In addition to all of that, if we find the opportunity and need present, we of course will provide and deliver supplies to new moms as well, just to ensure that they have the basic necessities for both themselves and baby. So next slide, please. This is my promise slide where I just wanted to highlight some of the work we do related to healthcare disparities, as particularly for maternal health. We have a dedicated interdisciplinary team approach where we have care coordination, utilization, management. We have our network teams. I mean, anyone that I could ring in for this discussion, I brought them in with a goal that we really started to look at what are ways that we can enhance outcomes, enhance education, and make sure that we partner with organizations who really, really address and have a deep interest for communities who may be experiencing disparities. And so we've been able to do some things like enhance health literacy through developing education on what to expect at each of your OB appointments. So at your 3-month mark, what are you going to expect? To really start to, again, enhance that health literacy. We have remarkable partnerships, and I, of course, would need an entire scroll to list them all, but really have had the opportunity to work very closely with Birth and Color RVA, Urban Baby Beginnings, Nurturing Amenities, Petersburg Pregnancy Support Center. So really just really digging into our ability to touch those community partners to really ensure that we have those, again, well-rounded health outcomes. Next slide. And here's just a little bit of a breakdown of our Watch Me Grow program as we start to enter into that infant baby phase, and how we have a dedicated EPSDT coordinator who, again, looks at some of the gaps in care, to help with appointment scheduling, also gives information and education on whether it's dental varnish, lead screenings, immunizations, well visits, all of that to really help the family health through this trajectory. In addition, we've had some embedded case managers in very different facilities across the state. So again, we talked about some of those hubs where we have some access challenges. We try to ensure that we have some additional resources in those settings, like Johnson Health out in Southwest, New Horizons and Eastern Shore, to make sure, again, we have that wraparound service perspective. Next slide. And with that, just looking ahead, we really want to expand our programming while we have a maternal child health focus to really start looking at some of the trajectory of women's health across the entire lifespan. Because we know if you're healthy and you start out and you're taking your folic acid and you're not smoking and you're eating healthy and you're getting your exercise, you have a greater opportunity to have a healthy delivery. So we want to keep everyone healthy, particularly with this Women Health Program expansion, to ensure that we have, again, additional education and focus, engagement with primary care, checking those HEDIS and STARS measures, getting mammograms, looking at colonoscopies, those adult immunizations, pneumonia, flu's in there as well. So I'll dabble in a little bit of my old state quality life here, where we really took our flu pieces from our CAP survey. So a lot of it was member reported from the official submissions. However, internally, we do track by claims who's getting those flu and immunization shots. And the great component about that are the additional activities and engagement with primary care with our premier population health events. Really, truly, prior to COVID, we were really hitting the ground hard, getting individuals from a provider perspective, those folks who had paneled populations with high care gaps. And so those individuals with providers who had panels with large care gaps, we were able to be on site with them, invite members out. We would make phone calls to get them into the practices to help close care gaps. Those are the things that we want to rev back up. So we are looking forward to that level of growth and continuing to expand our services moving forward. Next slide, just for the sake of time today. All right, and I just really wanted to hit you with a success story, because I always like to end on a high note if possible. Just wanted to let you know we did have a provider who was unable to contact a pregnant member, secondary to some hospital follow-up. Really wanted to have that appointment completed. That provider reached out to our Healthy Heartbeats team. We dispatched our team, and this was actually during the pandemic, to do an emergency home visit, and of course followed all those social distancing rules and regulations and recommendations. And within that, we were able to make contact with a member. We were able to get them into our Healthy Heartbeats Heartbeats program, connected with transportation resources so that they didn't miss additional appointments. We set reminders internally to make sure that, again, that member was aware. Not only were they getting that reminder from their provider, but they were getting it from us as well. We were able to find them temporary housing because there was some concerns regarding the conditions present within the existing housing, and that was through connections with our housing specialists. So just that one visit and that one level of escalation from the OB led to a remarkable outcome for this mom. And on that level, I will just end here to say thank you so much for having me today. I echo Marissa and Natasha's sentiment that the collaboration that we have received from DMAS, our community partners, providers, has been remarkable. And it's truly the way that we move the needle in outcomes. So thank you again. And I am more than welcome to take any questions if there are any present today.
Hi, my name is Vanessa Walker Harris. I'm from Department of Health. Thank you so much for your helpful presentation. Really appreciate that you all are intentionally thinking about caring for women over the life course. And to that point, I understand that the Maternal Mortality Review Team report from 2019 looked at chronic disease, and one gap was making sure folks are getting appropriately referred during pregnancy to manage their comorbidities. You mentioned MSM. Does the work there include, referring folks appropriately for other comorbidities?
Absolutely. As a part of our conversation, we always ensure this particularly falls in with our high risk folks. So, say for instance, they are at a point and they have diabetes and they've got some gestational diabetes, and we know blood sugars are skyrocketing. We will help them get the education and help with that navigation to get them to an endocrinologist. If they have, for instance, we have an established relationship for individuals who have Parkinson's and some other seizures disorders, neuro disorders that may impact or affect their pregnancy outcomes. So we try to support and do that level of assessment. In addition to, we will request medical records from whether it's our OBGYNs or our fetal medicine specialists where we may have concerns to help reinforce that plan of care. So if that means they're saying, I would like you to see XYZ specialist, and that member needs assistance getting into a specialist or making an appointment, we will help them with that. Should we, and just going to be full transparent here, we know oftentimes specialists have limited availability. There are challenges around getting some of those appointments. And sometimes when you think about accessibility and that network adequacy, there are challenges. If we ever get to that point where someone has a referral or a recommendation that they need to actually follow up with another specialist and there are appointment challenges, we engage our network development team and ensure that we're able to get that person to the specialist they need. And from the beginning of our conversations, even when we would do that review of benefits, we talk about primary care, ensuring that you have a primary care provider who's following you through your care. And this will be someone, if you establish a relationship with now, it'll be easy to pick up, or if you have something else that comes up, that you continue to follow up with them. And that includes starting the conversations and ensuring that a pediatrician is available for a new baby as well, or any other children who may be in the home. So it is definitely a well-rounded approach that doesn't just stop at the education or the review of records or the assessment, but goes on to really be that direct intervention to route members directly to whom is needed.
Thank you.
Great question.
I have a question.
Yep, go for it.
I was just going to ask Chantel, thank you so much for all the information. You mentioned how the extent to which you all go and make sure that your members are connected to resources. Have you seen an increase in WIC participation? And I know that Virginia as a state has historically underutilized WIC. So to what extent are you trying to help make sure that the people who are eligible for WIC are actually getting enrolled?
That is actually a part of our initial assessment. When individuals are identified as pregnant, we do an assessment and talk about, do you have access to food, all of that good stuff. And within that, WIC is identified as a potential resource. We have even gone as far as, because I've heard kind of in the background, we haven't necessarily experienced this lately, but I'd heard just some rumblings that there were some challenges getting into the DSS offices for WIC, and getting those applications completed. I want to give you a great example of how my team actually goes out and goes the extra mile. When we had some of those concerns, we actually had a meeting with Petersburg's DSS office and met directly with their WIC team, and really got some additional insight on how they're structuring their application process, how someone, still can't walk in, they still have to make appointments, things of that nature. Having that open dialogue gives us additional insight into how we can support our membership based on those regionally available resources. So WIC is one of our primary connections and primary resources that we look to, and we kind of go that extra mile to make sure the relationship is established with those DSS point to point contact. So absolutely, WIC is has been one of our great resources. I hope that answers your question.
Great. Well, Chantal, thank you so much. I'm sure we could sit here and pick your brain for a lot longer, but for the sake of time, I'm going to say thank you. But I know we have your information, so I hope it's all right if we offer that folks can reach out to you directly if they do have any kind of follow-up questions. And yeah, thank you again for your time today.
Absolutely. Thank you, Sarah. I told you, long-winded over here. Thank you.
Oh, but lots of good information, so we appreciate it. So members, we are just gonna kind of wrap up with a few little things. First, discussing what you were interested in talking about next meeting in March. Before we get into that, I do just want to mention that we will be having a new member orientation directly before our March meeting for new members. So we'll be sending some information out to that. It is open to anyone who wants to join and just kind of get a refresher over what our committee was formed for and kind of what is our scope and history. And then we'll roll straight into the meeting, and it will be one of our in-person meetings as well. But if there are specific things that folks would like to throw out there as possible agenda topics, we would love to hear it. Feel free to put them in the chat, unmute yourself, or just email Hope and I after the meeting if that's easier for you as well.
Hey folks, hopefully you can hear me pretty well. Yep. Yeah. Okay.
Yeah, hey, Freddie.
So I think I'm interested, if it's in March, that kind of lead up right before the end of the public health emergency, it stands, and so that children are like at really high risk of being disenrolled. I think it could be cool if you think this is the right space for it, an update on like targeted outreach engagement to parents of Medicaid CHIP children, and just to hear from folks a little bit about that as it pertains specifically to children. So I want to throw that out there.
Sarah, this is Heidi.
Yeah.
This is sort of a no-brainer, but we would obviously want to get an overview from Medicaid and anyone else where it's relevant about what happened in the session.
Mm-hmm.
And possibly an update on preparation for the unwinding, maybe, we don't know.
We never know. I will note there are some updates tucked into the member packet. So there are a few little updates in there for folks if they want to review that as of now. But yes, as we all know, it will end eventually, and it would be great to know exactly when that would be, but we don't yet. All right. Well, obviously always available. So let me know if other things come up. We can also review kind of things that we went over last year that were still open questions. I know there was a lot of conversation last year when we talked about school-based services, and I think that waiver is actually still pending. So we can, keep an eye for things that change between now and then as well, and different updates like that. Yeah, WIC is interesting because, correct me if I'm wrong, WIC is run through VDH. So streamlining that in with the other benefits is challenging. But we can definitely add that onto the list and ways of talking about just other supports that these families need. Hope, before we move to public comment, can you just make sure I haven't missed anything that I should have gone over today?
Nope, I think you're good.
Okay. Well, fantastic. Thank you. And then, so we are just going to move to public comment. So, Hope, I don't know if non-committee members can unmute themselves or not at this point. There we go. Directions are up. Thank you.
Great. Yeah, and Sonia, if you can confirm that that will work with WebEx.
And for anyone who's on the phone and can't see the slides, it says if you're joining by phone, you can unmute yourself by pressing *6. So that is how you can make a comment. You can also always submit written comments online in the chat or directly to the committee. And if you are in the WebEx, you can just click the microphone and unmute. I don't hear or see anyone, so we'll just give it another second just to make sure no one's struggling with the tech. Right. I do not believe there's any public comment today. So thank you all for your time. I appreciate it. I know it was a long meeting, which can be hard on a computer, but thank you for your time and your interest and attention. Thank you if there's any speakers who are still on for all the information you shared today. And I hope everyone has a lovely rest of your week and rest of the holiday season, and we will see you in March.
Sure. Hope.
Yep, go.